Dr. Chait, Kinetic Rehab and Spine. Welcome to our channel. Click the link below to subscribe, share, and like our videos. Join today, join the movement, gain access to insiders' education on how you become a better you. Welcome to your destination of health and wellness. All the best. Sempre Avante. Always forward. Dr. Nick Studholme, how are you doing, brother?
I'm great, Evan. How are you, bud?
You know, I'm so happy to see you.
Mutual. I think I was trying to think how many years it's been, but 10 maybe.
It might have been. We were at Doug's wedding.
I was at Doug's wedding. Yep.
That was the last time I think we saw each other, and we met in an advanced running course called Enhanced Running, right?
Absolutely. Yep.
Almost
Peak
10 years
orbit.
ago,
Yep.
and you got me really into the barefoot running and the Vivo barefoots, and I have actually 10 pairs now, by the way.
Of the Vivos. Yeah, nice.
Vivos, all the way from Germany. Now, you're a unique breed. You're a doctor of chiropractic and you're a mechanist, right? Biomechanist, right? And so I wanted to interview you because your perspective on how the body functions, how it moves, how it interrelates with not only the cardiovascular system and, so you have such a unique approach to how you work on your patients clinically, but you also teach, correct?
That's right, yes.
All right. So can you just go into your background a little bit about how you became a chiropractor and why you went down the chiropractic route versus physical therapy? Because,
Sure.
classically thinking physical therapists are more biomechanists, or even
Absolutely.
a podiatrist that focuses
Yeah.
on biomechanics too, right? So can you just give me some background on that? That'd be awesome.
Happily. I grew up playing a lot of athletics, and I just vividly recall one time sliding into home. Maybe I was 12 or 13, and I irritated somewhere in my upper back. And I went to see our general physician, and he just sort of assigned rest. And my mom took me to a chiropractor, and he adjusted my, I think, a thoracic-costal area or somewhere a rib. And I had instantaneous relief, and I was able to play that night. And it was such a cool experience for me. And I think, most of us, we get shaped by sort of our influences when we're children. And so that was the first experience. I ended up taking my chiro out to lunch, I think, in high school and talking to him quite a bit. And he was he's still a friend and a mentor, and I worked with him at one point, but he's a different breed. He does a lot of functional medicine and nutrition. He's really the sort of sick and tired of being sick and tired.
Yes.
So it was never the traditional bone out of place model, which it is not one that resonates with me in the chiropractic world. So I think always being pushed into slightly a more hopefully evidence guided model, if you will. And he highly recommended one of several schools. There's sort of schools in chiropractic that vary in their different philosophical approaches. And he just said, look, you need to understand how to diagnose it. If something walks in the office, you can identify it, and whether you should actually be seeing it or not. The rest of it, you can go learn at another time. So the school I went to probably had a bent that was more rehab and movement and mechanics. And I think that was sort of the beginning of that interest level for sure.
Mm. And currently, when you work do you predominantly work with athletes or do you work with everybody?
It is everybody. Absolutely. I think we probably see, it's funny about working with athletes because yes, some people can have the luxury of doing that. But if you think about every day of the year and multiple days in a month, you'd have to see a lot of athletes to have an entire athletic practice, right? I think we still see a high proportion of high level and, college level athletics, probably higher than most chiropractic offices, but absolutely we see every day, a lot of chronic pain, but with the idea of trying to get them back to activity.
Understood. And your facility, I saw your facility, it's beautiful. You have a whole entire gait lab, right?
We do, yeah. So we have a full biomechanics lab, really. We have an instrumented treadmill. We have what are called IMUs, which are 3D motion capture sensors, essentially we place on different body parts. We have force plates, high-speed cameras, and so we're able to really capture sort of any aspect of movement that we're interested in.
And so once you diagnose a dysfunctional movement pattern, then from there you create corrective strategies?
That's generally the idea. I mean, we're heavily influenced by a course we teach, and I know you and I privately talked about this, called Neuro-Orthopedic Rehab. It was formerly functional neuro-orthopedic. rehab. And, we use gait as our window in because gait is really subcortical. And so the idea being that it's mostly reflexive, right? So you're going to see a true picture of how somebody is moving without a conscious control of that. So if somebody is walking and you see a certain frontal plane movement, that might be different than a squat because a squat is a consciously driven motion. And so we use gait as one of our main tools. And then, of course, sport specificity or activity specificity. And then based on that, you're right, we create then strategies that are designed to, change the strength or the control or the mobility of what we see as an issue in those movements.
Interesting. And I saw that you studied with Dr. Buehler.
Yeah. So grew up seeing an applied kinesiologist, and that was a big influence on me. And I always struggled with the manual muscle testing as far as an objective measure. And the thing that Craig introduced me to, Dr. Buehler, which was really important and a huge part of my journey, was using a FET system to measure force over time. And for 2 years, we worked with that system to actually show that you can create a reproducible muscle test. So I think my biggest knock on all muscle testers is unless you've actually used a system to give you feedback, like anything else, you're manipulating a test. We've never seen a person whose first time using the FET system actually is doing a reproducible test. So Craig really helped me at least gain some comfort with this idea that we can create a usable muscle test and a reproducible one. Yeah,
because I know a lot of attention could actually, it could alter the muscle test.
Well, we assign a lot of value to a muscle test, right? And then yet we don't realize that we might not be using a reproducible outcome. And that's always been an issue.
What's Dr. Buehler's website?
Yeah, I think it's amitmethod.com.
Good. Okay. Yeah. So the listeners, because it used to be known as Chiromat, correct?
Correct. Yeah. So he was working with muscle activation technique as well.
Yep.
And so the idea was
right?
the idea was there was going to be this hierarchy from the massage therapist up to the chiropractor, and the egos get involved, and there was some fallout. And so Greg Roskopf took sort of Matt and went one way, and Craig rebranded just in an effort to distinguish the difference there. So
when you do your biomechanical assessment on people using the treadmill and force plate, right, and using the FNOR technology, right, because that's pretty much, what is it known as now? It's not FNOR anymore.
We dropped the functional because for lots of reasons, including it doesn't add much value. It is Neuro-Orthopedic Rehab.
NOR.
Yeah, exactly.
So when you do your NOR assessment, from that data, you could actually put them on the table and then actually evaluate muscle function on the table in an isolated perspective using muscle testing.
Yeah, you're trying to correlate the two, right? Because if you take, for example, somebody who has excessive, let's say, frontal plane movement in their hip, and you see that in gait, you want to then understand, or let's say limited, that's maybe a better example in this case, limited ankle movement in walking. You then need to understand, is it truly a limited movement or is it a motor pattern, right? So the table assessment, you're trying to correlate back to. And if the two don't correlate, you then have to ask yourself, well, why are they not using it in gait, but they have it available in function, in other movement patterns? Or on the other hand, does it match? Meaning it's limited in gait, it's limited on the table, and then the strategy changes. One is a mobility strategy, one might be a strengthening or motor pattern strategy.
Understood. A top-down versus bottom-up approach.
To some degree, absolutely. Yeah, absolutely.
Yeah. And so when you do the NOR assessment, talk us through that process. How long is the assessment process? When you work with a patient, how much time you're allocating to that patient in a single visit, say on initial evaluation? How does that look like in your practice?
Well, yeah, right. And, I think those of us that practice normal have some consistency, but nonetheless, mine is a little different. I've always run a one-on-one sort of fee-for-service based, for me, value add type practice. And so we spend about an hour and 40 minutes, and I'm probably on the long side. But the whole game is when somebody comes in this is the NOR model, we're planning for functional independence. We're planning for self-actualization and that patient's ability to not be in front of us, right? And patients that take an active role in their care get better. So the history and the conversation is a big part of that, making sure we really don't that we don't gloss over that component. Because as you know, in pain and chronic pain and frankly in injuries, language is really important, and we don't want to create these nocebos.
Correct. All the neuroassociations.
You got it.
Yes.
And then you have a full-time athletic trainer that works with me, and together we then go through our eval, which is we talked about a biomechanical eval, where we hook up our sensors and walk and run and possibly jump, depending on the task. At least walking, many times running. And then we do sort of our movement exam. We film that as well. And then a table-based exam. And at some point, then at least some sort of intervention at that point, ideally if we can address pain. And the NOR model really, one of our main neurologic sides, and everyone always wants it to be brain and brain-based. And, everything ultimately is, but the NOR model has a heavy focus probably on peripheral nerves and peripheral neurogenic inflammation in the peripheral nervous system. So many times we might then do.
How does that influence pain?
Well, profoundly. Because as soon as you have a sensitized peripheral nerve, it can mask and mimic multiple things. It can also create inhibition of surrounding tissue. It can create movement avoidance patterns, and it can also mimic conditions that aren't the condition. So, and many clinicians know this, but I think it's also overlooked. So somebody comes in the door and let's say they think they have a plantar fasciitis. Well, you can quickly treat a posterior tibial nerve, and if they get some instantaneous relief, you might realize that they may also have plantar fasciitis, or they may just have a neurogenic inflammation. And if you miss that, then you're not addressing many of the components that might be going on in addition to the biomechanics.
Let's pause that right there. So in Chinese medicine, we talk about root causes, right? And there's a saying in Chinese medicine: to treat disease, must treat the root. It sounds like the NOR system will teach you to analyze, but also find out where the root of their pathological movement patterns coming from and their source of the pain. Is that correct?
Look, that's the hope, right? I mean, I appreciate that the body's complicated and there are billions of connections, but we definitely believe that biomechanics, there's been a pendulum swing in the pain science world, that movement doesn't matter. You just need to talk about pain and talk people off the ledge. And I mean, I'm grossly oversimplifying.
Yes.
We disagree.
That's research done by Butler, right?
So, among many others, right?
Yeah.
But we disagree. We think biomechanics absolutely matter. And in addition to the pain science. And so if we can, as you mentioned, identify these areas, and in chronic pain, we know that there are areas of the brain that create motor cortex smudging, et cetera. And so if we can put our rehab towards these areas, we know that if we can improve how somebody walks, which is such a human function, they're going to feel better. And if we can then improve the mechanics that might be antagonizing that peripheral nerve, for example, then we've dealt with the peripheral nerve locally, and then we're changing the biomechanics around the peripheral nerve. And we're talking about, the pain science behind that, and generally speaking, getting a really good result, and one that the patient is actively involved in the rehab.
That's fascinating. Yeah, getting them to participate is really important. Now, how much does the visceral somatic reflex play in chronic pain?
The visceral somatic reflex? It's a good question, Evan. I wish I could answer that. We don't get in. I mean, the course itself is limited by time. So we don't get into visceral related. We stay at the peripheral nervous system for the most part. And we also talk about brain and brain-based related things. And so obviously the visceral component can have an impact, but we don't go into any visceral manipulation or evaluation or diagnosis.
Understood. Now, if somebody want to take your classes, say physical therapist, it's open to physical therapists, chiropractors,
athletic trainers,
personal trainers too.
Depends. We sometimes will make exceptions. There's some, degree of treatment, and so it just depends on what their scope is, where they are.
Understood. So you don't have to be licensed to adjust or manipulate to be able to.
We don't go through anything like that. No, if we show any manual-based techniques, it's all around peripheral nerve-related stuff. We assume that people are already coming in with a skill set of whatever they do.
Gotcha. Now, say there was a PT clinic that had a lot of volume. Can we apply the NOR concepts on assessments and say they only have 45 minutes to be able to do an assessment?
Absolutely.
So it doesn't have to be an hour and 45 minutes. This is what you do in your clinic.
Yeah. So Dr. Stuart Fife, who's one of the co-founders of PT, and in fact, much of the actual meat and potatoes of how the approach goes is really from Stu's experience. And he, for many years, worked in high volume clinics, and currently still the way they work is, I think, each patient is with a PT, and it's changed with COVID maybe, but I think he had 5 employees and seeing, a lot of patients during the week, and each patient spends 45 minutes in the office. So, and that's new patient and or follow-up. And so you can easily model this in a rehab fashion and approach that does not demand the time that I take.
That's great, man. But in your local area, having a clinician like you in Colorado, where are you in Colorado?
I'm in Denver. Yeah.
So in Denver, traveling 60 minutes and 90 minutes to see you for a 2-hour session, I would do that.
You're right, because we're going to film the rehab, voice it over, send it to you. So hopefully, the value add is high. And the component is, if we can teach you what to do. Look, a lot of people just want to lay around on a table, right? It feels good. And so we need to, unfortunately, break people of that. Not that there isn't value in manual techniques. I think there is, but I think we have an over-reliance on it, and patients only want that. So a little more time, a little more energy in those initial visits, but on the other hand, then less time between visits as people are assigned what they need to do.
So you're a breath of fresh air for a lot of people that just don't have time to
Absolutely
commit, even though it's an hour and 45 minutes, but it's not as often as
Correct. So our follow-up visits are 20 minutes typically with me, and then 20 minutes with my athletic trainer. And so if we, for example, are chasing something, I'll do some manual technique and or try to create more mobility or whatever the intervention is. And then my athletic trainer will then maximally try to drive that from a rehab standpoint to create as much plasticity as possible immediately after.
I love that.
And so there's still 40-minute visits, but we weight them equally so patients recognize that my time is as valuable as my athletic trainers, meaning that their movement and their activity is as important as the time they spend on my table.
And so what modalities do you use? I know that you talked about Dr. Bueller's work. You also do some sort of taping that's unique as well.
We use a lot of dynamic tape, which is very different than kinesiology tape for many reasons, and we can get into that possibly in another call. I don't want to eat up a lot of the time here, but I encourage anybody. It's mechanical tape, and the kinesiology tapes aren't. So we can use that to manage load, which is profoundly important in speeding back rehab or offloading an injured tissue. So we use dynamic tape. We have a class 4 laser. And then we use a lot of a product called Prologel, which unfortunately is currently not available due to COVID and the run on containers for antibacterial stuff. But Prologel is a phenomenal topical for neurogenic inflammation.
Oh, wow. That's
good. So we use those, and then, I use some of
your product, or you?
That was, although it's not related to the Neuro-Orthopedic Rehab, it was a product that was designed based off of injecting saline or dextrose into something called neuroprolotherapy, and then realizing you can do a topical. And that was created by David George and Stu Fife, who also helped found FNOR. So
how would the audience be able to gain access to that?
Well, currently they can't, unfortunately. Okay. But if you go to prologel.either net or com, I should really know, but if you type in prolo, like prolotherapy, but prologel.com, I think it'll bring it up, and you can see, and I highly recommend. It's really been a game changer. We know these peripheral nerves are sensitized not only mechanically but chemically, and so if you can mechanically attack them and chemically simultaneously, you're going to get a much better.
I love it. So we'll have the website in the blog, so don't worry about it.
Yeah,
I'll have all the websites. And what's your website if somebody in the Colorado area wants to see you?
It's it's drstudholme.com or studholmechiropractic.com.
And how do you spell your last name?
Right, STUDHOLME, and then the word chiropractic.com.
And the NOR seminars, where would people be able to gain that information?
Those would be at fnor.net.
Perfect. I know right now COVID's hit everybody. And the seminars are probably not being offered right now unless you're doing
They're
virtual.
online. I mean, we just did one to Australia on Australian time zone all last weekend. So, you know, we were on from, depending on, Stu was in Savannah, and Dave was in Arizona, and I was in Colorado, and Brett in Australia. But nonetheless, you know, our time zone, I think, was 5 p.m. to 2 or 3 a.m. We were on for 3 nights to a 9 to 5 Australia group. But so we are offering them still virtually for 25 hours. And I think the next one's in September. It'll be shoulder, neck, upper extremity.
And you're offering CEUs for PTs, chiros, acupuncturists?
Unfortunately, I think the CEUs are currently only for chiropractors.
Okay. All right.
Yeah. So
right. That's good to know.
Yeah.
So all the information's on fnor.net?
.net. Yep.
.net. Perfect. Dr. Studholme, you know,
Evan,
it's always amazing to see you and talk to you.
Like,
we're kindred spirits.
I know.
We
live so far away. Love to catch up, you know?
Yeah, man. Well, thank you so much for your time, man. And I want to do a follow-up so we could maybe go into your
Absolutely.
lab.
That'd be fun.
We actually see what is actually being done and performed.
Yeah, be happy to do that.
I think that'd be incredible.
Absolutely. I appreciate you taking the time out for this and supporting us. It's just great to see you, and thanks for helping out.
You're amazing.
Thanks, man.
I'll speak to you soon.
Yep. Take care.
All right, bye-bye.
Bye-bye.